Hi guys, welcome to sessions 3. I hope you've had the opportunity to look at sessions 1 and 2, but now we move on to 3 and we're going to talk about coma and the not necessarily the ICU patient, just patients in a coma. At some point in your nursing career, you're going to find yourself taking care of a patient in a coma if you've not already done so. This is a true story of one of my co-workers. She tells us the story that in the ICU there was this patient who was in a coma. He had been in a coma for about 2 weeks. One night, she said, there was a code. And you know, when there is a code blue, everyone rushes off to take care. All the attention is focused on that one patient. Shortly thereafter, she said, they heard a noise, and someone rushed to find out what had happened. And they found the patient lying on the floor, and according to what she said, this patient said, all along I was in a coma, I could hear what you were saying, but I could just not respond. Now this patient had fallen to the floor because the bed rails were not secured. And I'm not suggesting that this is what you do to jolt a patient back to reality. I'm saying that this patient woke up after falling on the floor and related this story. Next, let's talk about what might lead to coma. To learn more about coma, please go to intracranial pressure monitoring. Actually, patients in a coma might have ICP monitoring. To learn more about this topic, please go to dearnurses.com and read about meningitis and ICP monitoring. What reasons might patients be in a coma? Well, sometimes it can be medically induced in order to keep the intracranial pressure under control. It might be brought on by trauma, a stroke, some kind of bleeding event like intracerebral bleeding, meningitis. Even the patient who has a problem with the liver or kidney might go into a coma. Hypoxia, which is a lack of oxygen. There are just numerous causes why patients may go into a coma. One thing is clear, that even when a patient is in a coma, they will have a blood pressure, temperature, respirations, and we continue to give them good care until they wake up or whatever decisions are made. Now let's go talk about the Glasgow Coma Scale. The Glasgow Coma Scale is typically what we use as a scale to decide how alert our patient is. You know that it categorically starts at 1 and goes through 15. There is no 0. It's broken up into eye-opening, verbal response, and motor response. Let's take the case of eye-opening. We know this usually happens spontaneously, or it may be to verbal command when you ask a patient to open his eyes. Of course, if you're having sometimes if you pinch a patient to pain, you get a response. But then if there is no response, you never put a 0, it's a 1. Now let's take a look at orientation. You may have a patient fully oriented and awake. You may have the one who's awake but confused. And how about the inappropriate patient who tells you, when you ask him what day of the week it is, he tells you who the president is? And how about the incomprehensible who makes sounds like like a cow maybe? Well, if there is no response, that brings you back to 1. And how about motor response? How about the patient you have who obeys commands, withdraws to pain? But what about the one you get no response from? Also brings you back to 1. So if you have 1, 1, and 1, then that's 3. And I'm not going to decide for you exactly what the criteria is, because if many paramedics will tell you when they pick patients up in the field, when they go out on some of these emergencies, that when they got these patients, they were 3 literally until they administered care and then brought them up to a higher coma scale. Now let's move on to some very compelling stories. I have taken care of patients who've related stories like these. Nurse, while I was asleep, an angel was standing at the bedside, and who am I to argue? Next, we have the patient who tells you who was having a brain incident. While I was being worked on by the doctors and the nurses, I remember that I saw this beautiful place full of beautiful flowers that was like heaven. Then you have the next person who tells you that while I was in a coma, I could hear everything the doctors and nurses were saying. Please avoid negative feedback. Do not stand over a patient and talk about all the ridiculous things like how high the fever was and who had the last sin, who had this patient before, and which patient you don't like taking care of. How would you feel if you were in that situation? So do try to be a little bit positive when you stand over these patients. Look at what this nurse is saying. Nurse, the patient is being, the sister is asking a question, how's my sister doing? And listen to her response. She's a vegetable, I see no hope for her. How do you think that patient feels? Now, as far as I'm concerned, we cannot always determine when a patient, a family member says to you that I know my sister or so is not completely out of it, it's not worth arguing about. And the reason I say this is many times a familiar voice will get a different response over an unfamiliar voice. Many family members will relate stories like they had that patient squeeze their hand or blink an eye at them when they ask them to, because that communication comes with a familiar voice. So we should not write these things off. It would be very good at least to document it on the assessment. So when you speak to the coma patient, try to be more positive, more encouraging to the family. If there's something to dispute, take the patient and the family member aside, discuss it away from the bedside so as not to put the patient into a state of fear. What next? Please stay posted for more clinical issues, as these will be coming on and on. I cannot give you a definitive date, but it should be fairly soon. Have a good week.